Hi, Caroline. I can see you too.
So it worked. Now.
Work now. That's all right.
Good afternoon.
Is it because letting people in?
Maybe. Thank you for joining us for Dementia Matters, part 2 of 2.
5 to minutes.
My name is Phoebe James, and I'm a Professional Development Officer with the Primary Health Network. Before we begin, I'd like to acknowledge the traditional custodians of the land I live and work on. For me here in Newcastle, it is a Awabakal land, and pay my respects to elders past, present, and any First Nations people joining us today. Just want to mention before we start that this session is being recorded. The recording will be available in the Education Library on the PHN website in the coming days. At the end of the webinar, I'll put a link to an evaluation in the chat. Please fill this in because it does give us some good information. If you have any questions for our presenters, please put it in the chat box and we'll ask them as we go. It is now my pleasure to introduce to you for a second time, Professor Dimity Pont and Carolyn Gibson. I'll hand over to Carolyn.
Okay, Phoebe, I will just say, now I can't see me. Can everyone see me? Am I visible?
I can still see you.
And I disappeared when everyone came in off me. Oh. Who knows? As long as you can see the slides, that is excellent. Welcome back, people, and welcome to anyone new this week. So today we're going to be looking at part 2, and we're going to look at more of a practical aspects of what we were doing last week. And let me just get started. We don't know what's going on with our teams. So first off, DTA would like to respect and acknowledge the traditional custodians of these lands. We extend this respect to elders, past, present and emerging, and to all Aboriginal and Torres Strait Islander peoples. We also pay respect to Aboriginal and Torres Strait Islander peoples living with dementia and their carers. And I live, work and play on Wadawurrung land in Western Victoria. We won't worry about that one. If everyone could just do a quick thing of this QR code, and they just have 3 questions, the same ones last week about knowledge, skills, confidence. I think as I said to everyone last week, I'm more interested in the last one where we get you to put in any free text that's on what you think or what we might be able to include or might be useful, more useful, that sort of thing, so we can keep meeting your needs. So I'll just give that a few seconds. And I'll move on. So last week, and for those of you who weren't here, these are the sorts of things we covered last week about why knowing about dementia is important, a little bit about the nuts and bolts of dementia, recognising change and impact on function, and how to start having a conversation with people, because it is can be a fairly challenging topic, not just for the people we're talking with, but also for us initiating these conversations or trying to answer people's questions. You will all get sent, I think you can get to view the video, or at least you get sent the slide deck. So if you haven't got that, you might get it at the end of this session. So today we're going to look more at the person-centred, team-based approach, okay, to identifying potential healthcare needs in the context of a cognitive impairment. And we're going to use a case study with diabetes as an example of how we might approach, how we might best support a person with self-management of the chronic disease within the context of a cognitive change, and how that might be different to if we were just looking at diabetes by itself. And I'm going to, because it's so important in early dementia, in looking at advanced care planning, and it is quite challenging. And I know this wouldn't be everybody's role, but some people might be interested in it. It is at least worth knowing how to start the conversation and where to point people to, because it's really important that people do start thinking, putting in advanced care plans, enduring powers of attorney. And in fact, it's important for everyone to have those in place, but with dementia, there's some other considerations. And the other one is just about looking after ourselves, because it can be a difficult area to work in, particularly if you're in aged care. or something like that, where you're looking after people that are in challenging situations that, can often be distress themselves, can often cause distress amongst others. The very first thing, and I'm going to throw this over to Dimity, is I just threw this in a couple of, not an hour ago, is this week we had some new information out, which I think is important when we think about why dementia matters. So dementia is now listed as the leading cause of death in Australia. If you remember last week, it was the second leading for men, but the first for women. It's now the leading overall. Lecanemab, one of the medications, was approved by the TGA today. We've got new work happening on the blood markers. And also, I didn't really mention enough, like we usually do, about mild cognitive impairment, which kind of links in with lecanemab and potentially blood markers. So I'm going to throw over to Dimity to explain to us sort of what the implications of this might mean and why it's even more important that we're here and learning about this and take this back into our practice. Thank you, Dimity.
Okay, so
broad, but go for it.
Can you hear me?
Yep.
Yep. Okay. Welcome, everyone. Yes, the announcement about lecanemab, which came through late yesterday, I think, or anyway, certainly this morning. So this is the second in a class of medications for dementia that has been approved by the Commonwealth government by the therapeutic goods people. It is not yet available on the pharmaceutical benefits scheme, so it can be used, but people will have to pay privately, and it won't be cheap. I don't know what the exact cost is at the moment.
They said in the Guardian this morning that including the MRIs that you have to have, it can cost up to $100,000 a year.
Yes.
You might want to explain actually the MRIs, because how it works, the whole process, because I only know little bits about it.
So, well, the other one, donanemab, is costing around that 80 to 100,000 a year.
Yeah.
And that didn't go forward to pharmaceutical benefits scheme approval. So fingers crossed for this one. So why didn't the PBS approve it? Well, they said with the other one, donanemab, that the balance between the benefits and the harms was not right for them to approve it. So what are the harms? The harms with the other one, as with this one, are brain swelling, possibility of brain swelling, and little hemorrhages in the brain. That doesn't sound good, does it? It's less than 10% of people who take the medication. But in order to check for that, you need to have monthly brain MRIs, which are quite expensive. So that adds to the cost. It's not just the cost of the drug, but it's also having these MRIs, I think for 6 months with the other one. I don't know what the schedule is with lecanemab. On top of that, it's an infusion monthly. It has to be given into the vein. So for those of you who are working in the rural surrounds around Newcastle, that's a barrier because you'd need to get to a place that can do an infusion. So that's the harms. The benefits are that it will slow progression of the disease. And we're talking about Alzheimer's disease. You might remember last time, those of you who came last time, that there are various sorts of dementia. And Alzheimer's disease is the most common, 60 to 70%. But then there are many other sorts that people might have. Second most common, vascular dementia, caused by high blood pressure and high cholesterol and diabetes and so on. That's 20 to 30%. So not all of your patients will be eligible for lecanemab. And another problem with it is that if you've got the gene for dementia, the ApoE4 gene, then you've got much more chance of getting your brain swelling and hemorrhage. So you're not eligible for it. So that you have to have that gene tested before you get prescribed this. And that in itself is a challenge, guys. So if someone comes through your practice and you're the practice nurse or the GP, I don't know if we have GPs online, you have to tell them that they will need their genes tested. And if they've got the gene for dementia, not only are they not eligible for this medication, but they've also got an increased risk of getting dementia. So it's and if they've got a double copy of the gene, they've got quite a serious risk of getting dementia younger, and certainly a higher risk as well. So that it's a delicate conversation. Furthermore, they want people to start it very early, at the time when they've got mild cognitive impairment, which is a stage before the dementia diagnosis. And mild cognitive impairment doesn't always lead to dementia, but some people get better, and sometimes it goes on to dementia. So how can they be sure and give people this potentially toxic drug? Well, what they need then is a blood test for Alzheimer's disease. They're not interested in the other sorts at the moment. The blood test is for Alzheimer's disease because that's what the medication is for. And so we had a look at the slides last time, and you saw the cell bodies in the brain which have got amyloid in them, and then the fibrils that go out from the cell bodies connecting with other fibrils to send messages backwards and forwards. Those have got the tau protein in them. And the blood test is for the tau protein. And if there's tau protein in the blood, there's a chance that you've got Alzheimer's disease. It's not quite black and white. If you've got low levels, you may not have it. It has to be followed up. If you've got very high levels, you've probably got it and you'd be eligible for the drug. And at that stage, you may not have all that much in the way of memory thinking problems. So that's a really big bridge to cross. And you will undoubtedly be crossing it with some of your patients because they will want to chat about this. And the GPs, as always, I'm a GP, so I know, we don't have enough time to chat about it properly, and people don't always want to ask us everything they want to ask us. So that's the challenge, and no doubt you'll be asked. And Caroline and I discussed this before the meeting and decided that we'd put up this slide and explain this to you. So Caroline, is there anything else I need to explain?
No, I just think there is the potential people will ask you about, oh, what are the new drugs? Or I've heard there's a new drug that'll cure, dementia or Alzheimer's. And I think it's just being aware that, so being approved by the TGA is the first step to becoming maybe getting on the PBS. And lecanemab was kicked back. So it is an infusion medication. So when you think about it, it's going to need a lot of other resources, nursing staff to monitor people having infusions, facilities, the rest of it. It does have side effects. And then you've also got the blood marker tests and trials going on. I think, though, where I find it interesting is that I think when there's this idea that there's a cure and that, I often do think we'll get doctors maybe prioritising looking at people with potential dementia a bit closer. I think as a nurse, my attitude is it's kind of irrelevant to me. I think that we care for people because they've got cognitive impairment that's impacting on function in their lives in a way. So, but I think we will be asked, and we don't need to know the answers, but at least if we sort of look like we know, oh yeah, I have heard that before. I'm not sure, maybe to talk to your doctor about it or something, but just to be aware there are new medications coming out, new tests coming out in this area. And the idea of being able to recognise things fairly early on, such as mild cognitive impairment, which is a tricky one because mild cognitive impairment's a diagnosis in itself. It doesn't necessarily lead to dementia. It can be reversible. But people compensate, so it's changed where people compensate. So they can still do, some cat's dropping fur on me, they can still do all their activities. It doesn't look like they're being impacted too much because they're compensating. So if they're forgetting things all the time, they'll be initiating themselves to set up alarms or sticky notes or calendars or whiteboards, things like that, or maybe using a Webster pack. And they will have initiated that because they're worried they'll keep forgetting. But we need to be able to start recognising this a bit earlier and thinking, oh, maybe we do need to look into this a bit more. So it's all just very timely that all these things are happening.
And I should say, Caroline, I didn't make this clear, that it's not so far been shown to be a cure. It
It's not a
delays
cure.
progression, like dementia progresses, as we explained last week.
It would flatten, wouldn't it? Then flatten the line.
It flattens, so you go along. You've still got a bit of cognitive impairment, memory and thinking, but you could live like that for much longer and still be independent with your extra notes to yourself and the Webster pack and that for longer, which is much better, obviously, right? I'd much prefer that than going to nursing home. But nevertheless, I'm not cured, and eventually I would still get dementia. And we haven't got any cures from anyone having this. This has been used now for a couple of years overseas, so we haven't got any actual cures yet.
And we don't have that longitudinal data yet. So, I mean, what is it? It's the trials over 3 years show a 6-month slowing. So you get an extra 6 months. And I can't quite figure out what that means, but it's not massive, but it is enough that everyone's very excited. Anyway, let's rock on. On to person. And anyone, if you've got questions, please put them in the chat and we'll attempt to go as we can, because hopefully, Dimity, you can see the chat because I've got the slides. So how do we identify potential healthcare needs and develop care strategies? And what I do is I call these cognitively aware care plans. So first, just thinking of what do we do as, say, usual. And look, I'm being general here. We all do things differently. And if we actually get person-centred enough and understand about dementia and address that properly, then we might be a bit broader than what I called usual. But generally speaking, when you call up, you've got someone in and you're doing a COPD care plan or a diabetes care plan or an asthma care plan, osteoarthritis care plan. I mean, we've got these sort of templates often set up. We certainly did in our software. And they're even in the Medicare, I think, software as well, that you can pick up example templates that are disease focused, one condition focused. And but also our care planning is about supporting self-management. They do tend to focus on patient education, and yet they're supposed to empower the patient to enact change. So they're all it's a little bit contradictory in that in itself, but they're the sort of things that we tend to think of as usual care planning. But if a change in chronic condition management is caused by cognitive changes, not, say, a lack of knowledge or, I don't know, maybe depression or something different, maybe financial stressors, being able to afford good food or the medications. I often hear about people not purchasing medications because they can't afford them. But if it's cognitive, that's going to be quite a different strategy. And the one condition focused care plan is not going to work because the cognitive changes impact across everything. So that's sort of what we're going to explore now. So I've got a case here, which I've got half covered, which we're going to start with. And I'll bring Dimity in as we go. I know you can all read, but I'll read through it quickly. So we got Jenny here. She's 82 and lives alone. She has diabetes and she has some cognitive impairment. You know that because 2 years ago, she was at the memory clinic and they actually diagnosed her with mild cognitive impairment 2 years ago. And just for reference, her MMSE was 28. She's on some medications. She's missed her previous appointment, so you haven't seen her for a little while, and it might be unusual in itself. She's lost some weight. Her diabetes control isn't as good. Now, her daughter, Cheryl, has taken time off work today. She's come along with Jenny, and she's worried about her mum. She says that, look, she's not eating well. She's not taking her medications. She's been really difficult, ratty. She was going out a lot. She's not doing that. And, I'm just worried about her. And so this isn't necessarily an unusual story. And so what I want to do first, before it's hard, when we're all together in a room, we can usually go through this together. But if we think about what a usual care plan might be, is that the template comes up, and these I've just pulled out some little bits off the Medicare template, is it comes up, say, with general medication, lifestyle, then you might have other sections, mental health, mood, I don't know, there's a whole lot of stuff. I can't think of any off the top of my head at the moment. But if you come off some, say, because Jenny's come in, she's for a diabetes care plan, so you want to check her understanding, you want to look at medications, immunisation, and this one I've got lifestyle, so nutrition, physical activity, social connections. Sometimes I think we change the goals, but often I see them in people's houses and they're just generic: to have an understanding, to eat a balanced diet and maintain your weight. And if you think about it, everything tends to sit around patient education, and that becomes the care plan. But if you think about what we were talking about last time, about how you've got these different areas that can change, cognitive change, and what impact that's going to have on someone's self-management. Some of the ones I've got here, for example, if someone's got memory and learning problems, and remember, depending on the part of the brain that's been affected, you're going to have deficits in certain areas first. So some people don't present with memory and learning first. For example, I think I'd be right saying vascular dementia, Dimity, might not be so much that, whereas Alzheimer's definitely would be. And so learning new tasks or changes, so recalling appointment times or managing changes in treatment plans, like different medication regimes, things like that, that might not be very effective, So if someone's not managing as well, it might be because things have been changed and they can't relearn that new routine. It might be they've got difficulties in communication, so they can't really clearly tell people, medical practitioners, what's going on. They might have difficulty in that. Remember, we talked about dyspraxia, that coordination. And so maybe they can't manipulate the glucometer or the insulin pen properly. Or if difficulty recognising objects, I talked about that with someone's glasses half under the newspaper. So maybe they're not monitoring their glucose, not because they just can't be bothered or something, but they can't find the glucometer because the house is all cluttered or it's not in front of them. And again, executive thinking is about that idea of decision-making and processes. And that could be important around if someone has hypoglycemic episodes and trying to do those sorts of planning. They might not be able to comprehend and sort that anymore. So these are just some ideas on how cognitive changes might impact on someone's self-management of their condition, their diabetes in this case, and how when we go and look at care planning, we have to look at things a bit differently. So I'm just going to bring us back to the case, hopefully, with that, just to remind you from last time, that's what that other information was, about how then you might approach this if you're looking at it with a cognitive change lens. So I don't know, Dimity, throwing it at first to you, if you've got any thoughts on what people might do, how you might introduce the cognitive lens, what you might have seen if Jenny was sitting in with you in the GP office, and everyone else, if you're just sort of thinking through it yourself, if this person was sitting in front of you, this is what you knew, what sort of questions might you be asking her? What sort of ideas might you be coming up at that, forgetting of medications, what might you do? What might you want to know more about? I don't know, Dimity, do you have any thoughts? I'll just put you on the spot. Oh, can't hear you, Dimity. Here.
I think
Thank
Cheryl,
you.
you can hear me now. I
Yep.
think Cheryl's introduced the topic of memory by saying that Jenny's forgetting her medications. So Cheryl said that. I would be saying, probably to Jenny, I would probably be saying something like, so Cheryl's noticed you sometimes forget your tablets. Have you noticed that yourself? And have you had any other problems with your memory or thinking lately? And that, you know, that's not out of the blue. That's in the context of Cheryl already raising about the tablets. And of course, Jenny could say, no, I'm fine. Or she could say, well, actually, I'm not quite as clear in what I do. But it's just old age, isn't it? And those sorts of things, like that man in the video that we showed last week. But it would be a way of introducing the topic. And then I would start with prompts about, okay, so do forget medications. Are you having any trouble with cooking? I find that cooking in older women doesn't. It's much more challenging. And in fact, I ran into one of my older patients on a Friday night in the local Coles, buying some food, and I said, "You're very late here." It was like 7:30, and she said, "Oh yeah, I got halfway through dinner, and then I realised I didn't have all the ingredients. I've come down to buy them." So, I mean, I suppose someone can do that once, but if you're starting to do that often, there's a problem with your memory and planning. So, and then she's short-tempered and teary. So I could say, it sounds as though you haven't been feeling yourself. So could you tell me a bit more about that? So, and she's stopped socializing. So maybe you could ask a bit more about that. So there's ways of getting from this history and from what Cheryl's been saying, there's ways of starting to gently explore with Jenny what's going on. And Cheryl might know or might not know what's been happening, because I don't think Cheryl lives with her, does she? She just comes.
She works and has got her own young children,
yeah.
volunteers
So,
at the school. I'm giving her things to make her busy, so she can't see it often.
Yeah, so that's right. I've got a patient exactly like this with two daughters who both are like that, who are very concerned, and now they've taken to ringing every day to see how she's going. So that's a strategy that actually isn't a bad strategy, and that you could suggest to Cheryl, because it's very worrying having a mum who's not functioning as well and you're not quite sure what's going on. So anyway, I'll hand it back to you there, Caroline.
So some of the things, so I agree with everything Dimity said. Some of the things that would go through my head, off the top of my head, is one, she's got diabetes. That's a really big risk factor of a dementia. She has had a diagnosis of MCI 2 years ago, and we know what the MMSE was, so we could do a repeat one of that. Seeing if it's gone down. What is it? It's 4 points a year, they say, significant. Is it 4?
Yeah.
4.
Yeah.
Drop in 4 points. I mean, this again,
you can lose
is just
2 and it might go back up the next year. But
yeah,
4
but 4. So if we start noticing 4 a year, that's where it becomes more significant. Because I mean, she might have also had a bad day, but they did. I mean, the memory clinic diagnosed it with MCI. One of the red flags too. Oh, okay. Sorry, the cat just scratched me. I'm having a terrible pet day today at home. So the one thing too that always is a red flag if she's taken time off work to attend. Cheryl has never come with Jenny before, so Cheryl is worried. And so that instantly that happens before she's even opened her mouth and said a worry, she's worried. It also means that there's likely to be some tension in the room because Jenny doesn't want Cheryl there, because Jenny is doing fine and doing everything for herself as far as Jenny's concerned. There is no problem. I don't know why she's interfering, and I don't know why she's here. And so one thing you're going to have to be sensitive of, and we talked about that last time, I think, with around having the conversation, is that you want to take the heat out of the situation straight up. So you want to sort of say to Jenny and Cheryl, depending on the dynamic in the room, that, oh, it's lovely to meet your daughter today. It's great you brought her in. Give the power back to Jenny. I don't know if it'll work, but you could try. And then say, and then Cheryl, and then I say that, look, Jenny, is it okay if Cheryl lets us know why she's a bit concerned, and then you can let us know how things are going, and we can work as a team, put it all together and work out how best to support you and what you want to do. And then I would start going into what Cheryl is concerned about, keeping an eye on Jenny and being reassuring to Jenny. Because if Jenny has got cognitive changes, which obviously she's had some, you don't want to put her on the back foot and get defensive, because that then closes down the conversation, which when we were talking about last time, we want to try and keep that open, non-judgmental, non-threatening. And we're always trying to push the idea, Jenny, we are here to support you to do what you want to do. And if that happens to be because your brain's not working so well, so be it. Some people it's because their legs aren't working so well, and I just try and normalise it a bit. And then you often will find Jenny will work with you because she's not feeling threatened and she is feeling like she's going to be supported. It works better at this early stage because there still can be some judgment, rational type insight. It can be a little bit more challenging the further you go down the track. I think you'd agree with that, Dimity, because you can get people just blank up, say, no, back off. You know everything's in a shambles at home, but as far as they're concerned, they're doing everything for themselves. And that's when it's more challenging, I think. I don't have a solution necessarily for that. That one's just one step at a time, do the best you can.
And Caroline, I think I've learned from you as a nurse, and we GPs can learn lots from you guys, is that for Jenny, if she says everything's fine, that's her truth. That is not necessarily, in the case of cognitive impairment and dementia, it's not necessarily that she's deliberately lying to cover up. For her, she actually is not seeing the problems. She is simply not seeing them, and she is telling you the truth. She's not being devious. She's not being resistive, or she might not want you to do anything, but she's saying that everything's fine is because she sees that it is fine.
Yeah, and I think that's really important
to realise that.
Yeah, it is her truth, and I think. And that's where I think you end up with a lot of those tensions, is you're challenging their truth and you're essentially telling them they're lying. And a lot of carers, and this is where, when it is, say, more advanced and there is no insight or limited insight, that it's really important to somehow get the carer to stop challenging them, because there's no point and it just creates really difficult situations. And it's hard when, say you've got... I don't know, someone looking after their husband with a dementia, and the husband doesn't think there's a problem, and so he won't accept any help, and you're doing everything and you're becoming exhausted, you're really tired, you're sick of asking him to do things or having to do them yourself, etc., and also saying, no, you can't go and drive, and no, you can't, don't do that anymore, this, that, whatever. They're already like at a really high level of stress, and they're going to come in and talk to you, and they're just going to, when he starts saying, oh no, I do this, that and the other, there isn't a problem, and the wife then says, no, there is, you don't do all this, you've instantly set up this challenge to the person, to the husband, that you're lying. And so it's really good if when you set up the situation, like I said at the beginning, and say, oh, Jenny, it's great that I can meet your daughter, and to the husband, it's great, to see you both here today. We're going to look at how to support you, Jack, doing the things you want to do. Is it okay if, I know, Irene gives us some information too? You may disagree with her, but that's okay. And then you try, and then I say, and we'll take turns. And so, because often you'll find Irene is often being the spokesperson. If Jack does have some cognitive impairment, it often will be Irene is the one who the doctor speaks to over Jack. Other people speak to over Jack. And so you'll find there's this history of Jack being sidelined. Now he knows he's being sidelined. And so you just want to try and bring it back to a position of equal respect, of giving everyone a go. No one's challenging anyone or telling anyone they're lying. And it can be done. And it's just constantly trying to stop that argument. And also telling, say, Irene, that, look, sometimes you've just got to go with it. You've got to let some things go, because the things that don't matter, just let them go. I used to have some people that were rearranging the cupboards, or they do the dishes. They like doing the dishes. And so, but they were breaking them. And so we got some of was it melamine, whatever it is, the stuff that doesn't break. It took the wife a long time to accept that, because it wasn't the good crockery or the right thing, but it meant that the person could still do the task, still have some meaning, still have some independence, still feel like they're contributing, but you weren't getting the broken crockery. Things get put in the wrong cupboards and you can wear that, let it go. Pick your battles. And don't argue and disagree. You might as well just go and hit your head on the wall. It won't make a difference. And all you're doing is creating more tension, more anxiety, and most probably more arguments. It's a rather convoluted way of going about it, but hopefully that makes sense. Did you want to add anything, Dimity, or I'll just wrap up?
I think that's great.
Yeah. So, as I said, so Jenny comes in. She's seen the doctor first. She's coming to you. The doctor would have looked at the medications, had a conversation, maybe exploring a little bit more about what's going wrong here cognitively, getting a gauge on that. Spoken with Cheryl. They've come into you. Jenny's most probably already a bit on the back foot because the doctor's only spoken with Cheryl. And so you're going to calm the situation down, and you're going to start thinking, okay, Jenny's diabetes is not managed as well. She's having a care plan. We know this little bit of information. We know there's some cognitive changes. So we're not going to just provide education on how important it is to manage your diabetes and this how you do it, because we're aware that Jenny needs something a little bit more, well, person-centred, a bit more subtle than that. And there's some other issues in here. So if we go to more and think about what are the identified concerns. So she'd had some weight loss. She wasn't active as much physically because she wasn't going on her walks. She wasn't as active socially. She'd stopped going out and that. Her medication, she was forgetting some medications. And we know, I said possible MCI, but we actually know there's MCI. It should be all possible dementia. It might have advanced into a dementia, even though we know that it doesn't always, it might have. And so now we've got to think a bit more cleverly and think about, okay, we know there's some cognitive changes. Are they the reason for these concerns? So with the weight loss, is it that she's no longer able to get the shopping? So she's not being able to get the groceries. And so that's going to be tricky, because if you don't have the food in the house, you can't cook it. Or maybe she is getting shopping somehow, like she can actually do that part, but she can't sequence, even though it'd be difficult to organise a taxi if you can't sequence. But maybe the actual cooking's more difficult. Or maybe she's been given a fabulous new Christmas present of a new kitchen appliance. Maybe she's now got an air fryer and a microwave, and she can't learn to use these new items. So you need to sort of think about, we wanted to prepare more nutritious foods, but is it a dietitian referral she needs for weight loss? Or is it someone to help her with shopping or to support her around making cooking easier? So occupational therapists are good for functional assessments and looking at task simplification. And so they can often get into the home, and whereas often we can't. And they can look at what can we do to help Jenny still cook meals? Or maybe we do have to go one step further and look at delivered meals. Keeping in mind, delivered meals don't always work for some people with cognitive changes. Hang on, I'll just click that person in. If there are some problems in that they've still got to be able to peel off the wrapper and they've still got to be able to use the microwave. And if they're delivered ever in foil dishes or they get things that can't go in a microwave, again, it can be problematic. So it's really important to work out, is it a cognitive concern? Is it a cognitive change underlying the concern? And then what might that cognitive change be? And then how do we match our strategies to address that? So we're not actually, so we're addressing the weight loss, but in a different way than if they didn't have a cognitive change. That makes sense. So again, physical inactivity. So is she just lost interest, doesn't realise that it's important or what the value of it is? But is it also because she's easily disorientated? So maybe when she goes out of the house now, she's reluctant to go out of the house, whether it be for shopping, physical activity, social stuff, because when she goes out, she becomes confused as to which direction she's going. I can't remember people's names, things like that. Just that underlying anxiety, which we talked about was really common in early Alzheimer's disease. And so maybe what you need is not the education and the encouragement and the persuasion that, no, this is really important. I want you to walk, around the block every night, full stop. That's on your care plan. That's not going to work if it's because she's anxious. What you need to look at then maybe is there's a walking buddy. I think with Jenny, she used to walk in a walking group. Ask her, is there someone you trust to talk about this anxiety? Could we tee you up with someone? Or is there a formal service we can look at, like a social support is the service under My Aged Care. And someone will come with you and you can go off for a walk and then have a coffee. So there's other strategies. Social isolation, I use forgetting names there, would be a similar type of thing if it's around anxiety, forgetting things, short-term memory, is having that support person with you. So get her back to church weekly if that was something she enjoyed, but look about how can we get her there? And just telling her it's important and she should do it won't be enough. Medication management. Now this one's important, and often memory aids are enough. People don't need to jump to Webster packs or the sachets. Sometimes I ask people, what are the first thing you do in the morning? And it might be make a cup of tea, might be brush your teeth, go out and get the paper off the porch. That one could be more challenging for placing your medications, but you know what I mean? You need to then put the medications with the thing you do first thing in the morning. And or if someone has a whiteboard that they'll look at, or someone's used to using calendars, it's a routine for them, or a diary, have it written in the diary that, medications, somewhere alerting you. If that doesn't work, then you start to get more complex. You go for least intervention first. So,
Caroline,
yep.
Can I?
Yeah, because this is where I want to throw to you is around deprescribing, home medication use is where the GP really needs to come into play.
Well, but what I was going to say was Cheryl is there, and I was suggesting that with some of the daughters of some of my patients, they ring every night.
Yeah, that's a good one too. Yeah, to do a
so
prompt.
Cheryl could ring in the morning and say, "Hey, take the tablet." Yeah, and so and Cheryl would probably be much more comfortable to do that and know that they've been taken, and that mum's all right and she's up and dressed or whatever, and that might work well for both of them. So
Yeah, that's actually a good one because that will decrease Cheryl's anxiety as well.
yeah.
But you got to get Jenny not to get shirty about that because sometimes
Yes.
and or they'll Cheryl will come back and say, "Oh, she said she took them, but she hasn't." And
Yeah.
there can be, but it is a good one to try because you're always going to try with these first and see how they work. And then if it doesn't work, the biggest extreme, particularly with at-risk medications, is a locked box and nursing. And that's, so you've got memory aids at one end and say Cheryl being one of those memory aids. And then right at the far end, you'd be looking at district nursing in a locked box. I'm amazed how many people start that first, almost district nursing first, and you don't need to. Occupational therapists are good for advice again around aids that could be useful. There's all sorts of things. There's alarms, people put alarms on their phone and all that, but it's got to work for the person. And the last one I've got here is the cognitive change itself. And if we're early on, then again, we want to be looking at those risk factors. So we want the diabetes managed well because it is a big risk factor, is vascular changes. And the other thing, the key is optimizing independence. And so again, that's where we talk about the strategies being minimal intervention first. And really getting Jenny as much as you can to participate in the how are we going to get there and the goals. Because if they're not important to her, as they are with anyone we're doing care planning with, then it's not going to happen. I don't know if anyone had any questions or Dimity, you wanted to add anything or anything's in the chat.
There isn't anything in the chat.
Okay. Hopefully that made sense.
Yeah.
It's big.
Yeah, is big. And the other thing it would be great for the nurse to do is to check on driving. Is she still driving?
I don't think Jenny was, but I mean, oh, that's such a tricky one to get into. But it's worth knowing.
You'd refer it back up to the GP, probably.
Oh, God, yeah. But it'd be good to know.
It would be good to know, yeah.
But I'm pretty sure if Cheryl is rocked up, that'd be something she'd be telling you about.
Yes, she would.
And often you'll have, I've often come across like grandma picks the kids up from school several nights a week.
Mm.
And these become a big concern and Cheryl will be trying to stop that. Or I've had stories too that picks them up and then is supposed to prepare them dinner and they start getting quite weird dinners or not as complex as they used to be. They end up with a piece of toast or a sandwich or something. And there's all these subtle sort of weird things that you start hearing about, which indicate something. And that some changes might need to be made. So building on from this, and I sort of touched it. So the key things you want to think of is supporting the person. So what matters to them, optimizing their independence. We know from last session about how important social connections are in health, not just in cognitive health, in all health, and how social isolation has been shown to have the same impact on mortality, morbidity as smoking 15 cigarettes a day. We want to manage the comorbidities, in this case, the diabetes. We want to look at future planning and enduring powers of attorney. And we want to refer to my aged care. And just in those in themselves, when you look at some of those things, they're not things we do ourselves as a nurse. And this is why it's so important to be working with the GP, and the GP to be working with us, because it is a team. And if we get allied health involved, we need to know what each other's doing, which can be difficult because sometimes care is so siloed. We want to, as Dimity said, be looking at what Cheryl's needs are and support the carer. They need information. They need their own health and well-being looked after. Again, as we mentioned last week, people who care, so maybe not so much in Cheryl's case, but it was certainly she's causing her anxiety, which isn't good. But people who care are the carers, particularly the full-time carers for people living with dementia, have quite a significant increase in the rates of depression and other chronic disease. than do the carers of people without dementia. So we need to be promoting self-care and looking at maybe education and support groups, such that goes through, say, Carer Gateway or Dementia Australia. And the key resources, say, for you as the nurses, if you look at the Dementia Pathways tool, and I've got the links at the end, and this is a tool I did, I'll admit that, but I've gone through like that plan. I did it a while ago, but I think it's still useful. If you go through that, I've gone through all the separate little possible concerns, all the reasons it might have changed if it's cognition, and then matched it up with all the sort of things you can do. So it can be a sort of good idea about generating some clues about where you can start. It is a bit clunky, but it has got some information and resources in there. The other key places to go is Dementia Australia. There's My Dementia Companion and Forward with Dementia. They both have really good resources on them. Carer Gateway is quite good. And to find services, you can get people to contact community connectors or care finders. They're really useful at finding out who is actually delivering meals at the moment in the local community, who's providing personal care or domestic assistance. But I've got, again, those links. I just wanted to say these, in my mind, are the key ones.
I'll try and find them and put them in the chat for you guys. But they're at the end of the presentation.
Yeah, I've got the links at the end. I'll talk about because often we get asked, oh, who are your, because it's so important. One of the really big things that you need to be is embedded in, like, know what's in your local area. And I think you all know that when you're care planning and that. And I think that's something we're particularly good at as primary care community nurses, is knowing, and often it's other patients have told us, who's providing this, who's providing that, where there's a good social group, where there's a book club that's really accepting of people with different, cognition, what the library is offering at the moment. Because here, I'll go to it now. I'll come back to the other stuff, give you a very quick flash of what we're looking at. I should have put this on up. This is the Finding Local Formal and Informal Support Network. So My Aged Care, you need to get a referral in. It takes forever to be assessed. Dementia Australia and Carer Gateway will know local carer support groups. The Primary Health Network will have a localised health pathway, which will have local referral pathways on it. Service Finder is useful to find local allied health, such as what OTs might be available to you and how to access them. Community connectors and care finders have been funded by My Aged Care to help people find and connect with local services. Like in Ballarat, we have a community connector with council, and care finders are run by Wintringham and Catholic Care service providers. So people in the community, rather than ringing My Aged Care, which is really confusing, can ring these people and they'll actually work with them. They're from the local community and help them connect with services. Local neighbourhood houses, community health centres, libraries, the local paper and your own networks are really useful to find out, who's out there. I know in our local library for a while had someone who'd go out and help people set up an iPad for them, which was really good. So some people got new tech and they wanted to learn it, and there was this person who'd actually helped them set it up. So it was good to know about that. You don't hear about those things unless you're sort of listening to what's happening in your local area. I'll quickly zip back. Where was I up to? There.
Yeah, that's good.
So we mentioned the GP chronic condition management plan. I don't know, Dimity, if you wanted to talk about this as a GP and how this actually provides more of an opportunity to structure care and funded care, which is so important in primary care. Because it's fairly new. It is there, though, that you can claim that MBS at the moment, can't you?
Yeah. So
Is it in? Yeah.
Yeah. So so there's been a change with the chronic disease management, and probably most of you are aware of that, but I'm still getting my head around it, to be honest. But there is a care plan which gets prepared, and we don't have to send out to the Allied Health the way we used to. And then every 3 months you can do a care plan review. And I would imagine that certainly in our practice and in many practices, that will be the practice nurse responsibility. And for people with dementia, that's absolutely ideal, because you can ask them to come back with their carer if possible, and you can check with them and their carer if there's any new problems they've encountered, because dementia is a chronic deteriorating condition. So is there any additional help they need? Are they remembering to go to their allied health appointments? Because if they've got diabetes or something, they're supposed to be seeing the podiatrist and the optometrist and so on, and they may have completely forgotten about that. That really often happens, and you can remind them at these 3 monthly reviews. Have you seen the person? And again, have you seen the person? So I think it's an ideal opportunity, especially if you guys tend to be a bit more organised than GPs. Dare I say that about GPs? If there's a GP in the audience, you may disagree. But I find the nurses are very organised and can tick off things that they need to check next time, the 3 monthly review. And all of that earns money for the practice. So there shouldn't be any problem with you doing that from that GP's point of view.
And I think that's really important. It's that, like, one of the things we used to get told in feedback, one of the barriers to providing this sort of care for people with dementia is that it's time intensive. Like, they don't have the time they can put into it, and the time's not funded. There's not the funded opportunities. But now that you can do these 3 monthly reviews, that means, I think, it's a real opportunity to support people with cognitive changes, because you can touch base with them more often, because it does take time. You can't cover everything at once. It takes time for people to consider, to digest, to, especially, in the early stages, to work out that we're going to look at this positively and work out what we can do to help you. And people have to go home and reflect on that and think about it. And often you've got to test out strategies, because they might work, they might not work. And the ones that work today might not work in 6 months' time. It does keep you on your toes. But I think it does provide an opportunity for what I call the cognitively aware care plan, which isn't quite as straightforward. I think this one, oh yeah, I did put this one in here, yeah. So that's a real opportunity. But also remember, as we mentioned last time, there's the 75 plus health assessment, which is a good opportunity to pick up cognitive and functional change. And that 45 to 49, where you can talk about risk identification and reduction, which is what we talked about last session. And so it's just to remind you, there are opportunities that are funded and that can be used to do some of this work. And then, of course, it's just your opportunistic time. So if you're in the treatment room and someone comes in, and that was a bit like Mr. Bird in that video about wound care, and things are just not working out the way you thought they were going to, and you start thinking, well, why is this happening? And do we need to have someone visit him at home more often, or have a mixture of district nursing and him coming in here? Like, something's not right because he's not looking after the wound as he needs to. This one's a tricky one. I have to take a deep breath. Dimity, did you want to add anything more about, before we went on to advanced care planning, about the chronic disease management planning or anything? I think we've covered it pretty.
You might.
We can't predict it, so
yeah,
just
you
give you
might
clues.
even have to discuss it with the practice manager. Say that you've been to this webinar and you've been told that you can do this, especially for people with dementia, every 3 months. And can you set up recalls for that or something? She'd probably be keen, or he, and then of course the GP needs to know that that's happening as well. Yeah.
And you have to get off that focus, don't you? That so often I'd have people come in and before they even sat down, they'd come in for their care plan and they just said, oh, I'm just here for my podiatry.
Yeah.
You know, they just came in for their 5 podiatries.
The
And
referral.
or the doctor said I have to have a care plan so I can get physio. And I mean, that's not really what they're for. They're for supporting self-management, of which that might be a part. And so you've also got it most probably because if you're getting someone in every 3 months, they'll be like, well, why are you doing this? It's overdoing it or whatever. And so you have to put in some value, I think, and get people. I mean, it might be hard, but get patients realizing that, you're not just here to get your 5 podiatry for the year. You're here because, we're working on managing your chronic disease, supporting you manage it well so you live well and can do the things you want to do. So I imagine that could be quite a challenge too with some people. But we're talking about opportunity and that there are ways that we can address dementia, cognitive impairment in primary care, and that it is, given that it is the leading cause of death now, it has such a huge impact on people, community, and everyone around them and themselves, that we just can't continue to ignore it. I was going to do something now. This is the last bit on advanced care planning. It's just an introduction to some of the key principles. And it's not expecting that you do it, but it is understanding that this is a key part of care planning for people with dementia, because it is going to need to be mentioned that at some stage that it's going to be important to have enduring powers of attorney in place. One thing I do is I don't target it at the person with the cognitive change. I sort of say everyone should have one. You both should have one. The couple should have one. Appoint someone down from generation down and all that. So again, that normalising it. But what I'm looking at now is just getting an understanding of the different parts and an understanding that, remember, I'm from Victoria, Dimity's from New South Wales, people will be from other places. The law, of course, and the documentation is different in each state, but I will talk about that. So advanced care planning is, as it says, it's discussing and planning for care in the future when the person may no longer have decision-making capacity. So that might be, and this is where it's so important, is because of this cognitive capacity, but also it can be important that if someone, heaven forbid, had an accident or something like that, a stroke, and they couldn't make decisions for themselves, who is going to make that decision for them? So it's giving someone an opportunity, and this is what you're talking about. It's not that someone can override you. It's about, if you can't make a decision for you, who do you trust to make the decision that you want and you would make for yourself? And that's the key. And that's often how you get people willing to have this conversation with you. Because often I get the kickback around, oh, but I'm not going to let them put me in a nursing home. And it's like, no, it's not about that. It's about having someone who respects what you want and will make those decisions and be legally recognised to do so. So that's the advanced care directive. So that's the legal aspect of advanced care planning. It's about the documentation and the legal documents that mean someone can make a decision for you. Advanced care planning also includes what's called a statement of wishes. Okay, and that's more about a values statement. And it's when you see, it's like, well, what is important to you if you were dying? What is it you'd like around you? Who would you like to speak to? Do you want a priest blessing or whatever? That's more about that. So I'll talk about those elements in us now.
Caroline, can I interrupt?
Yeah.
I went to a talk by a legal person from the University of Western Sydney, and she said, when you're doing the substitute decision maker, the person who's going to make decisions for you, she said, often people default to the eldest child, or sometimes the eldest son. In my family, it was always the eldest son. If it was a daughter, they just got bypassed. And she said, please ask the person to consider if that person is reasonable with understanding implications of money spent and decisions made. So if that eldest child is or son is impaired in some way, it might not be the right decision for them to be the decision maker. And I'm thinking, alcohol, recreational drugs, and so on. And there's such a lot of pain in families when that's the person that ends up getting everything, because it often disappears and the rest of the family's still struggling. So, and you'll probably know these stories yourself from being in practice. So it's if you can just ask the person to reflect. You don't know the family probably, but just ask the person to reflect. Is this person the right one of your children to do this, or is there someone else that you should suggest? Does that sound fair?
Yeah, you want, so when I've actually got advanced care planning can include 3 things, and I've separated substitute decision maker out. So the value statement, appointing a substitute decision maker, and the documentation of the medical treatment you might like or not like. And number 2 and 3 can be both legal. But you don't have to do all of them. Sometimes people just do a statement of wishes or just do a decision maker. But yeah, that's really important. So when someone is appointing someone, what you want is them to appoint the person they know well and they trust, and the person who knows them. Often you'll end up in trouble, say, if the person they want to appoint is like the eldest child and they live overseas. They hardly see them.
Yeah.
They might talk to them regularly on the phone, but are they going to be the best person to be their decision maker should they not be able to make decisions for themselves, particularly if they're in hospital, for example, those sorts of health decisions. But yeah, so that is important. They want someone that they have the relationship with. And I talk about trust, know you know them, and you trust them to make the decisions for you. Some people won't do it. They don't want to appoint a substitute decision maker. You can appoint 2 that have to act concurrently, or 1, and then if they're not available, the second one can act. But that's when you start getting it more complex. Really, you just want to start off the conversation.
So, and Caroline, in New South Wales, we've got an enduring power of attorney, which does the money. And the enduring bit means that it clicks in if the person's had a stroke or they're hospitalised and can't make decisions. And there's also an enduring guardianship, which I think in Victoria is called a health power of attorney.
Medical decision maker now.
Medical decision maker.
Yeah. Well, and then a guardian's what VCAT appoint.
Yeah, in New South Wales it's got slightly different names. So you might need to check on all that.
I'll show you where to look to see there's some really good information out there and educational material, because I think it's recognised it's important. There's an advanced care planning website, Advanced Care Planning Australia, which is really, really good. And it's got videos, the documentation, things for people to take to consider who they'd like to be the decision maker, which asks those questions about who do you trust, and I've got the website down there, but that's where a lot of this information came from. So there's 3 types of decision maker. 1, you make them for yourself, independent. You are your own decision maker. There's a supported decision maker, and that's not a legal document. That is someone you nominate to support you make decisions. So someone works with you to make the decision. And then that one really came out of disability field. But people are using it in dementia as well, that conversation. And then you've got the substitute, which is the legal. And again, like Dimity said, the substitute can come in. You can have a power of attorney that acts now at any time, or they only come into play when you yourself have deemed to have not had capacity and not make the decisions for yourself. So the supportive decision maker, as I said, is not legally appointed, and they just support someone. So often you'll find that will be the daughter or the family member or someone who comes along with them, and they're called a supportive decision maker. But they can't override your own decisions. Whereas the substitute, as I said, is by law. And as we've said, states and territories have different legislation. And as we said before, it's really important because of the progressive nature. And we know that the uptake of advanced care planning, full stop, is poor, but people with early to moderate dementia, it's particularly low. And one of the real issues too with the documentation, that is the health practitioners knowing it exists. So if people do make them and you know they've got them because you ask them, have you got a power of attorney in place? If they do have one, ask them to get the documentation and you can put it on record. Tell them to put it on the record at the hospital. Gives a better chance of someone knowing that there is a power of attorney in place. Because usually when you need them, it's a stressful time already. Now, as I said, having the conversation can be challenging. Often people think it means they're dying. They often think, oh, it means you're giving someone else power over what happens to me or my money. It's not the will. Often people say, have you done this sort of thing? They say, oh, yeah, I've made my will. It's not about a will. That's part of it, I suppose, but that's not what we're talking about. It's not a one-off conversation. There's some tools around. I'm going to show you one that I like. Document the conversations, and things need reviewing. This is from the Advanced Care Planning Australia website. This is really good. You actually get it in a card. You can ask for some. They'll send you these cards. They're like A5. And it's good ways to start off thinking about what you might have in an advanced care plan, whether it's your values statement or the medical one, which is the legal one, medical treatment. It's things about being able to, X is the most important thing to me because Y. As part of my culture, value, beliefs, X is important to me. The most important things on my bucket list are. An unacceptable health outcome for me would be because, and so they can be good ways of opening conversations. Or if you're not doing this yourself, of giving it to people to say, look, how about, you might want to start thinking about these things. It's important for us all to think about and start having the conversations with your family amongst each other about these things, because people need to know if you can't tell them what is important to you. So you can just order those cards. There is an advanced care plan for people with, as they say, insufficient decision-making capacity. I've just clicked off the front here, but this is a form which it's not the legally binding one, as it says, because you can't give capacity to someone to make the decisions for you, but it can be nominating, say, who you want the clinician to speak to. If like this, who is the substitute? Who do you want them to talk to if I can't make decisions for myself? And it can include what is important to me. So it can still give you some direction. And so it's worth, even if people have got to that point, that there is still opportunities for them to have their say. And the last one I just had was looking about after yourself. And I think one of the things that is important is attending education such as this, because I think when we're educated,
Caroline, you're talking about the audience, aren't you?
Yeah, about your self-care.
That's right.
I think because people in aged care were really asking this sort of question. And I think part of it was that idea of working as a team, sharing the care planning and how to go about this. How do we problem shoot? Attending some education. And again, those normal self-care type things. I'm not going to worry about that. This is the question I asked you last week as we rocketed through all this. What might you do differently in your own practice now you have this information? Like what might be something you can go back next time and do a little bit differently? And so I invite you to think about that and to sort of have an idea, play around with a few things that you could do differently. It might just be looking up one of the resources. It might be around looking up, the advanced care planning type ideas. And then I'll come back to questions. That's the scanning code for the end. Now, did anyone have any questions in the little bit of time we've got left, or have I just overwhelmed everyone?
So I'll just say that there's a scanning code which we really want you to fill in. And there's also an evaluation which has just appeared in the chat, and which you, the PHN, really wants you to fill in. So so both of those, you need to do both of those. So just let them sit there for a few minutes. So
it helps inform what we do and what's useful for you. So it just helps us understand better, and the PHN understand better who they need to go and find to provide you with education sessions that are useful. So it's always nice to get back that sort of information. And if anyone can think of any questions while they're doing that,
chat and we can ask you.
Yeah, just ask us. And after this slide is a whole lot of resources I'll go through for you on where you can, any particular topic that you would like to say be your thing to take away and do differently. They're all in here, all the best ones I could find. And as I said, the advanced care planning website's really good, and it's got a really good education module on it. The advanced project, which is dementia specific training and resources for future planning, and it's really quite good. So you're not alone in any of these things. There are things out there that can help support you have these conversations. And again, you go as far as you're comfortable with, but even just letting people know it exists and it's a good idea is a great start. And there's other education sessions that are quite good. So I'll quickly go back to that code. But thank you, everybody. And I hope that was useful.
And happy to take any questions or comments, maybe via the PHN or direct.
Yeah, you can always send anything on.
Yeah. Hi, Phoebe. Sorry. Where did that come from?
Not the first time, don't worry.
Tired, need lunch.
Caroline and Dimity, just wonderful. Really, really great presentation. Thank you so much for taking the time. To everyone who has joined us, thank you for spending your lunchtime with us. We hope you got a lot out of it. And please do the evaluations, both of them. I know that's asking a lot, but we would be forever grateful. And take care of yourselves. Thank you so much.
Thank you, everyone.
Thanks, Phoebe. Thanks, everyone. It was great to see you.
Thanks. Bye, Dimity. Bye, Phoebe.